Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Warm welcome my dear students in my surgery lecture number 44, that is the hernia operations. In this lecture we will cover the herniotomy. The herniotomy, that is the bassinis repair, shoulderis repair, laparoscopic repair of the hernia, that is the tap and TAPA method, both treatment of the strangulated hernia and the femoral hernia. Now start with the herniotomy. The incision is made half inch above and parallel to the medial 2/3 of the inguinal ligament, that is the almost on the inguinal canal. Superficial tissue has two layers, fascia of Camper, the fatty layer, and the fascia of Scarpa, that is the membranous layer. Before the fascia of the Scarpa is reached, the two vessels are come across the superficial epigastric and superficial external pudeudal. The aponeurosis of the external oblique are cut in the same line. The external oblique aponeurosis is cut up to the superficial inguinal ring, so that the whole of the inguinal canal is exposed. An incision is made on the cremasteric fascia and the internal spermatic fascia. After separating the margins of the fascia, the white wall of the sac will come into the view. Then separate form spermatic cord of the blunt dissection with piece of gauze to minimize trauma to the structures of the spermatic cord. These separations should be started from the fundus and gradually extended towards the neck of the sac. Dear students, here is a good image of the herniotomy in the infants. You are clearly seen. This is the laparoscopic view where the hernial deep inguinal ring is closed by the suture. Now the neck of the sac is identified by the constriction of the neck of the sac. The collar of the extra-peritoneal fat wall be seen when the mouth of the sac widened out to be continuous with the parietal peritoneum. The inferior epigastric vessels will be seen just medial to the neck of the sac in indirect hernia and lateral indirect hernia. Then the sac is now open and the content are reduced. Neck of the sac is reduced by means of the transfixation sutures. The stump will disappear under the archaeal fibers of the internal oblique. Closure of the wound. The spermatic cord is allowed to fall back to its normal position. The external oblique aponeurosis is sutured in front of the cord by continuous catgut sutures. Dear students, here is a text image showing the inguinal canal is shown after the incision and reflecting the external oblique aponeurosis, and white string in the figure is the ilioinguinal nerve. And the second below diagram showing the hernial sac is directly bluntly of the spermatic cord. The third image is showing the hernial sac is being twisted after the contents are squeezed into the abdomen before transfixation suture is applied. And the below given text image showing the bassinis repair. Note how the sutures are applied through the conjoint tendon and the inner margins of the inguinal ligament. Now the herniorrhaphy, that is the bassinis repair. This means the repair of the posterior wall of the inguinal canal in addition to the herniotomy operation. Main aim is to strengthen the posterior wall of the inguinal canal by stitching the lower margins of the muscles, that is the internal oblique and the transversus, and the conjoint tendon to the inner margin of the inguinal ligament behind the cord. 3 to 5 interrupted stitches are applied. The most medial suture should be passed through the peritoneum of the pubic tubercle instead of the passing through the inguinal ligament, as this is the part through which most recurrences occurs. While applying the middle sutures, one must be careful hole biting the inguinal ligaments not to injure the external iliac or femoral vein, which lies just deep to the inguinal ligament. Overlapping of the external oblique aponeurosis is after advocated by many surgeons. This will increase the strength of the anterior wall. Dear students, here is another image on your screen showing the complete layers of the shoulderis repair is clearly seen in the image. Here is the stepwise images showing of the inguinal hernia is clearly seen. In the first picture, there is a complete inguinal indirect hernia, then the identification of the sac and isolation of the inguinal canal, then the suturing of the conjoint tendon with the inguinal ligament, and third is the placement of the inguinal canal and again suturing the external oblique aponeurosis. These steps are clearly seen in this picture. Now this text message showing the strip of the fascia lata is being used for the gauze method of the hernioplasty. This is the autogenous material which has been used for the hernioplasty. Other techniques which are used in herniorrhaphy are, that is the shoulderis repair, This is now a standard technique which is used is most indirect inguinal hernias. The transversus fascia is incised from the deep inguinal ring to medially as far as possible near pubic tubercle. The deep inferior epigastric vessels are safeguarded and the fascia is carefully separated from the extra-peritoneal fat. The fascia is now secured by the overlapping double breasting in which the upper flap is placed over the lower flap. Proponent of shoulder repair reports a very low recurrence rate in the last series of the patients. Here is a good animated picture of the shoulder repair you can see on your screen. Now the next point is if the deep inguinal ring is weak and staged, simple littlest method can be used. The cord is laterally displaced, the inferior epigastric vessels are carefully retracted and the transversus fascia around the deep inguinal ring is sutured to narrow the ring. And third is the dacron or other mesh implants. A Smarlex mesh patch is sutured to the aponeurotic tissue overlying the pubic bone and conjoint tendon above and inguinal ligament below. The medial aspect of the mesh should overlap the pubic bones by approximately 2 cm. The inferior edge of the mesh is sutured to the inner scaling edge of the inguinal ligament. The spermatic cord sutures are placed within the inguinal canal overlying the mesh. Ideal material, that is the polypropylene, dacron proline and expanded polytetrafluoroethylene is the ideal material for this. Material problem, mesh rejection and wound infection expensive and its lack of incorporation into the tissue by fibroblast and collagen proliferation. Recurrence rate is less than 1%. Now the next operation is the hernioplasty. Up to the excision of the sac, the steps of the operation are more or less similar to those herniotomy. Only difference is that in direct hernias for which this operation is mostly performed, the sac is wide neck and it is almost impracticable to use transfixation suture. The whole sac is pushed in and attention is directed more towards proper repair of the muscular defect to avoid the recurrence. The defect has to be closed either by repairing the defect by darning with some of the non-absorbable materials such as the fascia lata, that is the Galli's operation, a strip of skin, that is the Mayer's operation, the silk ribbon, that is the Gosset's operation, or braided nylon. Some surgeons prefer to use a strip of external oblique aponeurosis taken from the upper and lower margins of the same aponeurosis. But nowadays tantalum gauze or a polypropylene mesh is easily available and is often used to over the defect. This is the another image, takes an image showing the stainless steel mesh is being used for the hernioplasty. Now the laparoscopic repair of the hernia. The use of the laparoscope or minimal accessive surgery has become the trend of the day and now the preference of the surgeons. The laparoscope allows the surgeon to visualize the hernia defect and surrounding anatomies with enhance the clarity and magnifications. Two techniques being used. One is a TAP, T-A-P-P, and second is a TEPA, TEPA. TAP means the Trans-Abdominal Pre-Peritoneal repair and TEPA means the totally extra-peritoneal approach. The main hernia technique is same in both methods. The difference lies in the manner in which access to the pre-peritoneal spaces is achieved. In TAP, intraperitoneal approach is made and the peritoneal flap over the posterior inguinal area is incised to reach the pre-peritoneal space. In TEPA, the pre-peritoneal space is reached without entering in the peritoneal cavity. Dear students, for TAP and TEPA, there are very good videos of the hernial operations by the laparoscopy are available on the YouTube. You can refer it and watch it to clear your concepts. Here is a image of the site of the ports for the laparoscopic hernial repair. This is the laparoscopic view. A diagram shows the hernial defect, deep inguinal ring. Diagram B shows that is the structure of the inguinal ring, and C and D in the D diagram showing the closure of the deep inguinal ring by the stitching. This is the another image of the through the laparoscope. There is a left inguinal hernial ring is clearly seen. The epigastric vessels are there. Vast difference is looking clearly. Testicular vessels are there. Now this is the animated image of the laparoscopic repair of the hernia. That is the TAP, T-A-P-P TAP. Now this is the next image showing the blood goods rectus sheath and folds is being used for the hernioplasty. Now recurrent inguinal hernia. In approximately 10% of the cases, inguinal hernia may recur. Through recurrence hernia rate is more common in direct hernia. There are various causes of recurrent of a hernia. The causes can be classified as follows. Types of the hernia: sliding hernia, very large and long standing hernia, large direct hernia. Types of the patients: patient with chronic straining and chronic bronchitis, chronic dysuria and chronic constipation. Patients with weak inguinal muscles, that is the presence of long malgnates bulging. Third is the preoperative preparation. Straining factors has not been corrected properly by the medicine before operation. Fourth cause of the recurrence of inguinal hernia is the operative faults. Failure of ligation of the sac of the neck, a tension in the stitches in basin is repaired so that the portion of the muscles held in stitches become devitalized and repaired by the fibrous tissue, which yields use of the absorbable sutures in the repair of the inguinal canal. Imperfect hemostasis predisposing to infection. Faults in the selection of the operation. Herniotomy has been performed when herniorrhaphy should have been the treatment of the choice, or herniorrhaphy has been conducted in place of the hernioplasty. The fifth cause of the recurrence of the inguinal hernia are the post-operative care. Infection of the wound, which seems to be the commonest cause. Lifting of heavy weights within the 3 months after the herniorrhaphy, post-operative period. Persistent coughing, urethral obstruction and staining at defecation and urination. And the next cause of the recurrence of the inguinal hernia are the appearance of new hernia. After stratification, repair of the indirect hernia, a direct hernia may appear later on. Treatment of the strangulation inguinal hernia. Emergency operation is the treatment of choice to save the patient's life. As soon as the patient is admitted, he should be properly resuscitated. At the same time, an attempt should be made to reduce the hernia as gently as possible. Foot end of the bed should be raised to take advantage of the gravity for the reduction of the hernia. Ice bag is applied locally to reduce the congestion and edema of the tissues, and lowering the temperature of the content, chance of the gangrene is delayed. Nasogastric tube aspiration to decompress the abdomen to release the pressure. IV fluids, injection pethidine and atropine to relax the abdomen muscles to help reduction. Parenteral antibiotic should be the good practice. An attempt should now be made to reduce the hernia. Gentleness is the expected from the surgeon, otherwise complications like contusion or rupture of the intestinal wall. Reduction en masse, that is the sac together with its contents is squeezed into the abdomen, but the coils of the intestine within the sac remain strangulated. The symptoms are not relieved. Reduction into the locus of the sac may rupture at its neck and the content are reduced not into the peritoneal cavity but the extra-peritoneally. Now the viability of the bowel, how to test it? The gut becomes greenish and blackish in color. The gut becomes flaccid and lusterless and thrombosis of the mesenteric vessels. There is no peristalsis in the gut. When the fluid of the sac in blood, stained and foul smelling, there is every possibility that the gut has turned non-viable. It is always advisable that hot wet mops are placed on the involved loops of bowel for at least 10 minutes. Returning of pink color and peristalsis also indicate returning of the viability. When the involved bowel is viable, it should be pushed into the peritoneal cavity. The sac ligated at the neck and exercise of the operation is conducted as herniorrhaphy. If the bowel is non-viable, resection and the end-to-end anastomosis should be performed. Now the last point of this lecture are the femoral hernia. In this type of hernia, abdominal contents pass through the femoral ring, transfer the femoral canal and comes out through the saphenous opening. It is more common in females and accounts for 20% of cases of hernia. Surgical anatomy. Femoral ring is an oval opening, half inch in diameter, larger in women than the men. It is normally closed by the femoral septum, which is nothing but thickened extra-peritoneal tissue. It is bounded in front by the inguinal ligament, behind the pectineus muscles covered by its fascia and the pectineal ligament of the Cooper, and a thickened band running along the iliopectineal line. Medially by the free margins of the glimmernates ligaments, lacunar ligaments, laterally by the septum which separates it from the femoral ring. Dear students, here is a new image on your screen showing the various types of the external hernias, and there is a femoral hernial site is also shown on this image. There is the epigastric hernia, umbilical hernia, incisional hernia, inguinal hernia, then Spigelian hernia, and the femoral hernia is the site of the femoral hernia is also there. This is the special picture of the femoral hernia in the female. The site is different through the inguinal region, inguinal hernia. The femoral hernia is clearly seen in this image. The femoral canal is the innermost compartment of the 3 compartments of the femoral sheath. It is about 2 cm in length and is funnel shaped. The middle compartments of this sheath carries the femoral vein, while outer compartment carries femoral arteries. The femoral canal contains areolar tissues, fat lymphatic vessels and the lymph nodes of the cloacae. It is closed above by this femoral septum of the femoral ring. The femoral sheath is formed by two facial layers. The saphenous opening on fascia ovalis is an opening in the fascia lata situated 4 cm below and lateral to the pubic tubercle. The upper and the outer margins of the saphenous openings are thickened and sharp, known as the fasciform process. This process turns the femoral hernia upwards once it has come out the saphenous opening. Dear students, here is an image showing a schematic diagram to show the anatomy of the femoral hernial orifice. There is a Scarpa fascia covering the fascia lata, femoral hernial orifice, Scarpa fascia, head ligament, pubic tubercle is there, glabellar ligament, fascia on the pectineus, griviform fascia and the fossa ovalis. All anatomy is clearly seen in this picture. Now the course of the femoral hernia is like the femoral hernia comes out through the femoral ring, then passes through the femoral canal, then comes out through the saphenous opening and progressively opens in the subcutaneous tissue of the thigh, and hence the femoral hernia is clearly seen on the skin. Now the coverings of the sac of the femoral hernia are from outside inwards the skin, superfascia, the cribriform fascia, the anterior layer of the femoral sheath, the fatty content of the femoral canal and the femoral septum and the peritoneum. These are the covering sac from the outside to the inwards. Now the rare type of the femoral hernia, like through majority of the femoral hernia passes through the femoral canal. A few rare types may be seen as below. Prevascular hernia, that is the passes in front of the femoral hernia and behind the inguinal ligament. Second is the pectineal hernia, passes behind the femoral vessels between the pectineus muscles and its fascia, cloacates hernia. Third is the external femoral hernia, passes lateral to the femoral artery, that is in the Hazelbach hernia. Langes femoral hernia, lacunar hernia, occurs through a gap in the lacunar, that is the Glimbernatt's ligament. Now this is the clear picture showing, note the course of the fully developed femoral hernia. Now the clinical features, history should be taken and important. Age, uncommon children, majority seen between 60 to 80 years. Sex, much more common in females. Remember that even in the females, the commonest hernia in the groin is the inguinal region. Side, right side is affected twice rather than the left. Symptoms, there are two groups of the symptoms in the femoral hernia, that is the local and general. In local symptoms, pain, adherence of the greater omentum sometimes lead to the dragging pain. Swelling, small globular swellings is there. And in the general symptoms, the causes of obstruction is the abdominal colicky, vomiting, abdominal distension and the constipation are the general symptoms in the femoral hernia. Now the local examination of the femoral hernia are, first the position below and lateral to the pubic tubercle and below the inguinal ligament, whereas the inguinal hernia is positioned above the inguinal ligament medially to the pubic tubercle. Size and shape, mostly a globular swelling. Two important signs of the hernia are the impulse on cupping and reducibility. Consistency, majority of the femoral hernia feel firm and dull on the percussion due to the omental content. Now the next point is to differentiate from inguinal hernia. How to differentiate the femoral hernia from the inguinal hernia? First is the impulse on cupping by Siemens technique, that is the index finger put over the deep inguinal ring and ask the patient to hold the nose and blow the cup. If impulse felt on, then that is the indirect hernia. Middle finger put over the superficial inguinal ring and ask the patient to hold the nose and blow the cup. If impulse felt, then that is the direct hernia. Ring finger put over the saphenous opening and ask patient to hold the nose and blow the cup. If impulse felt, then that is the femoral hernia. Means at a time the index finger, the middle finger and the ring finger should be put over the deep inguinal ring and ask the patient to hold nose and blow the cup. If impulse felt on the index finger, that is the indirect hernia, and the impulse felt on the middle finger, then that is the direct hernia, and the impulse felt on the ring finger, then that is the femoral hernia. This is the good differentiation and to recognize the which type of the hernia that is. Now the by investigation test, inguinal canal feel empty. Ring occlusion test, when the hernia is reduced, pressure is exerted over the femoral canal and the patient is asked to cup, the hernia does not come out. Position, the neck of the hernial sac lies below the inguinal ligament and lateral to the pubic tubercle. Now the differential diagnosis of the femoral hernia are, this has been discussed as the above. Now the treatment, there is no place for conservative treatment and surgery should be performed in all cases of the femoral hernia. Surgery, basically these operations are herniorrhaphy, but the approach are different. Three types of the operation are performed. First, high operation, that is the MAC-AUD operation. Approach is made mainly above the inguinal canal but also below it. Lothesian's operation, the approach is through the inguinal canal. Lockwood operation, the approach is below the inguinal ligament via groin crease incision. By these three types of the operation, the surgery of the femoral hernia can be performed. Now, the image showing on your screen is the Lothesian's operation of femoral hernia. A showing the transverse fascia, B inguinal ligament, C conjoint tendon, and D neck of the sac. Now, the next image is showing the last stage of the Lothesian's operation. The neck of the sac is ligature. Stitches are passed through the conjoint tendon and pectineal ligament for closure. A showing the transverse fascia, B showing the inguinal ligament, C conjoint tendon, D peritoneum with the stump of the sac, E pectineal ligament, and F femoral vein. And the side image is showing the best incision for the strangulated femoral hernia, which gives simultaneous exposure of the neck and the fundus of the sac. Dear students, here we learn all the points regarding the hernial operation, and there are very good videos on the YouTube. You can watch it, the herniorrhaphy, herniotomy, hernioplasty, laparoscopic tap and TAPA, femoral hernial operation, these three types of the operation which I explained you. All these videos are available on the YouTube. You can watch it to clear your concepts. Here is the end of our surgery lecture number 44, that is the hernia operation. Thank you, students.